And first of all, I would like to thank you very much for inviting me to participate in this event. And it is my great honor and pleasure to be here together with this distinguished group on a very important topic, which is really important in our region, which we pay a lot of attention to that. As we, just let me share some slides. So, I mean, globally, we are facing increasing morbidity and mortality of cancers. In 2020, it is estimated that 9.6 million people died from cancer globally, and 70% of these deaths occurred in low and middle income countries, amounting to 7 million. Cancer is the fourth leading cause of mortality in our region as well. And it accounts for 23% of global burden of cancers and 20% of the cancer mortality. And just in 2020 alone, more than 700 new cases were diagnosed, and approximately 500,000 deaths were estimated. So, the incidence of cancer is going to increase considerably over the next 20 years. And it is projected that in 2040, the cancer incidence will be doubled solely based on the population aging and growth. So the diagnosis of cancer at an early stage and access to optimal treatment had a demonstrable effect on the decline of cancer mortality in most developed countries. However, cancer patients are usually diagnosed at an advanced stage in developing countries where human resources, physical capacity, and equipment and technology are limited. And the difference is really associated with access to quality care and cancer care efficiency. In cancer care, of course, health workforce is critical. And cancer care is provided by a multidisciplinary team encompassing such as oncologists, surgeons, nurses, radiologists, radiation technologists, medical physicists, radiation therapy technologists, biomedical engineers, and others and others. And nurses who correspond to more than 50% of the health workforce are also central and critical in oncology care. And they are key member of the multidisciplinary team, and they represent the largest group also in the provision of cancer services. They have critical role throughout the continuum of cancer care, starting with prevention and control, encompassing patient assessment, education and care of patient, coordination of interdisciplinary care, administering the treatments, identifying complications, symptom management, and also palliative care. So nurses are primary health professionals who offer bedside care to cancer patients, also engaging the family caregivers in caring of the cancer patients. Globally, oncology nursing is increasingly recognized as an independent subspecialization in some countries, especially in high-income countries. However, in low and middle-income countries, the area that still does not receive adequate attention and resources. Just to look at the broader context where the oncology workforce is settled, if we just would like to zoom out and we look at the broader health labor market. Globally, health worker shortages continue, with an estimated global shortage of 15 million health workers. 47 countries are in the support and safeguard list of WHO. And 6 of them are from our region. Actually, I mean, African region and Eastern Mediterranean region account for the most of these countries. And also we can see quite a number of countries in our region are below the threshold level to advance universal health coverage. We do not have much data in relation to oncology workforce, but the shortages have become more and more explicit during COVID-19 pandemic. And 2/3 of the countries reported that staff shortages were a significant reason for service disruption. And this included cancer care as well, it affected the cancer care. And when we look at the nursing situation, we have faced a global shortage of 5.9 million nurses. And the Eastern Mediterranean region accounts for almost 18% of this shortage. Globally, nursing workforce is aging, with 1 out of 6 nurses to retire in the next decade. And we still in our region have a younger nursing workforce, which may be a potential to cover potential pull factor for other countries. The education market is also affecting the skill mix. Even though there is increase in the education capacities for nursing over the last 2 decades, it is not enough to keep the pace with the population growth. And if we look at the ratio of nurses and midwives to physicians, we can see that the ratio of nurses and midwives to doctors are below in some countries in our region. And also there has been significant decrease in the last 20 years, because the red dots shows the ratio in 2000, and the bars shows the ratio in 2020. And we can see the decrease in most of the countries in our region. So this landscape has significant implications for nursing workforce and also for oncology workforce and oncology nursing. In the literature, we don't, unfortunately, there's not much information on oncology nurses in terms of quantity, etc. However, a study which was undertaken in our region and published very recently in a report reiterated that the density of oncology workforce is lower in middle and low-income countries compared to higher-income countries. And also, we don't even have information available in most of these countries. Even globally, the specialty nursing is emerging, but the numbers are still lower in our region. And with the global health workforce shortages and the increasing demand in health labor market, international mobility of health professionals, especially specialists, is increasing, leading to serious challenges and shortcomings. We can see that the share of foreign trained nurses in OECD countries are gradually increasing, and globally 1 in 8 nurses are migrants, and we see significant outflow from our region. For example, in especially Lebanon faced 30% in the last 2-3 years, lost the 30% of their nurses through migration. So access, not only the numbers, but access to quality services and quality cancer care is very much linked to the quality of health workforce as much as their availability. Equipping health workers with adequate competencies to provide the necessary functions, as I have mentioned in the beginning, which wide range of functions, is critical to ensure good quality cancer care. Nurses in low and middle income countries rely primarily on the job training in oncology, rotations in oncology units. So it might be important to provide some continued professional education opportunities to compensate this prior lack of training. And actually, what we can see is, there was a study, just not in general cancer care, but palliative care in the region, comparing how much nurses curriculum included palliative care. We can see that most of the low and middle income countries did not include much. And also the special further training related to palliative care was just emerging. And so some very few oncology nursing specialization programs are emerging, but also they face some resource challenges or faculty challenges. So there is also important to have some pathways to capacity building for oncology nursing. And we have seen some good opportunities with the video that we have just watched. So, of course, capacity building, scaling up the capacity building efforts is not enough. This should be accompanied with adequate employment and recruitment policies and career pathways. At the same time, enabling policies, regulations, including the scope of practice, needs to be in place for nurses and other health workforce to perform their tasks, and also ensuring strategies to optimize the use of existing health workforce. Nurses and health workforce, all health workforce, including nurses, are critical to provide care. Their availability and quality is important. But we may also need to look at from the perspective of the health workers working in this area. Studies have shown that oncology nurses have more stressors than nurses working in other units. They are at disproportionate risk of psychological distress as they encounter multiple ethnic challenges and deaths while providing cancer care. So, moreover, cancer patients are more vulnerable and to be disproportionately affected by outbreaks, crises, which in turn creates increased burden of work on nurses caring for such patients. And they often suffer from burnout, psychosocial distress, which is exacerbated during several falls of crisis, especially in our region. Half of the countries are in protracted crisis and also doubled with other natural disasters and outbreaks. So all this affects the attraction of nurses to cancer care, cancer services, as well as their retention. Given the high levels of stress and burnout experienced by oncology nurses, there is a need to develop special incentives and special working conditions. WHO pays special attention to nursing workforce. As you know, last year we have adopted the updated global directions of nursing and midwifery. And in our region, we have a regional framework for action for strengthening nursing and midwifery. And 3 years ago, our regional committee called for an action to accelerate the implementation of all these commitments. And also in our region, League of Arab States, in collaboration with WHO and UNFPA, again reiterated the commitment and adopted a League of Arab States nursing and midwifery strategic framework. So I think it is time to implement all these commitments, accelerate the implementation of these commitments. And at the same time, there are a number of capacity building activities are ongoing in the region, especially in countries with protracted crisis, to strengthen nursing workforce for cancer care. I just would like to conclude that oncology nurses are integral part of a cancer care team. And as the population's demographics and healthcare delivery systems change and new scientific and technology discoveries are integrated into cancer care in the coming decades, the role and practice of oncology nurse will continue to evolve, and it will require to strengthen and invest in that. Thank you very much.